So, dears, in the previous class, we have seen the hypertension. Now, today, we'll look into further the coronary artery disease or the ischemic heart diseases. This is super important again. A lot of questions are coming from the CADs. What do you mean by a coronary artery disease? So, you know what a coronary artery is, right? So, coronary artery is nothing but the artery which is supplying your heart muscle. So, any ischemia to those arteries will cause coronary artery diseases. What are the causes of these coronary artery diseases? Any occlusion in the blood vessels. It may be because of the deposition of the plaque. It might be because of the deposition of a clot. Any WBC infiltrations can occur. So majority of the conditions, the coronary arteries occlusions are leading to these coronary artery disease. And what do you call a coronary artery disease? It is nothing but a obstruction in the coronary arteries. So an obstruction in the coronary arteries are known as atherosclerosis, whereas an obstruction in other arteries are known as arteriosclerosis. Okay. So we have atherosclerosis as well as arteriosclerosis. Arteriosclerosis means clot in the arteries, which is apart from the coronary arteries. And if you're having a clot in the coronary, specifically if you're having a clot in the coronary artery, it is called as atherosclerosis. Fine. Now, what are the coronary artery disease and its managements? First one. First pathology of this coronary artery disease is it is that there is an increase in the lipid formation, especially the high density lipoprotein. So, a lipid formation, hyperlipidemia is a condition which predisposes a coronary artery disease. Okay. Second one is hypertension. So we have studied the hypertension, how alcoholism, how smoking, how the stress is leading to hypertension. You know that. So when there is when a patient is having such kind of pre-morbid conditions, there is high chance of developing the coronary artery diseases, right? Then a diabetes mellitus, a glucose intolerance. Why these? In case of diabetes mellitus, the sugar will be deposited and the glucose will be deposited in the coronary arteries. Again, cigarette smoking, lifestyle as well as the dietary management, lack of exercises, obesity, all these things leads to atherosclerotic condition. So I'm not saying that only the obese patient will be having these coronary arteries. You can see how the cine actor Puneet have died because of coronary artery disease. He was in his he was in his early 40s and he was fit. Was doing his exercises. He have never had an obesity, but in such conditions also we can see the coronary artery diseases. So in such kind of conditions, it might be a silent one. Okay, but those conditions are rare to occur, but yet it may occur. But the majority of the conditions, the coronary artery diseases, are affecting the persons who are having a lack of exercises. The obesity will also be a problem. Okay. Then plasma fibrinogen. That's what we have said the clot in the coronary arteries. So the clot can be formed in any part of the body. Like it may be a cause of it might be because of a deep vein thrombosis. So when we were treating for the deep vein thrombosis, the thrombus. What is the difference between a thrombus and an emboli? Thrombus is a clot which is attached to a place, whereas an emboli is a moving clot. Okay, thrombus is something. Thrombus is a clot which is attached to a place, whereas the emboli is a moving clot. Okay, so when we were treating for this DVT, the clot might have dislodged and it could come into your coronary arteries. That might be a reason for that. Then endothelial dysfunction. So your endothelium, the inner layers of the coronary artery should be intact and it should be performing smoothly. So if those endothelial lining is disrupted, okay, when the endothelial lining is disrupted, the WBC will be activated and it will deposit them. Yeah, which also leads to a clot formation. Any antioxidants uses estrogen deficiency. See, estrogen deficiency is mainly seen in ladies. See, in females, what happens is that due to the increased level of estrogen, the chances of getting heart attacks are lower. I'm not saying that they won't get heart attack. You definitely, ladies at any particular age of time can also develop heart attack, but when the estrogen the levels are lower, they are having a high chance of developing the heart attack. That's why you can significantly see a lady who's having a heart attack after her postmenopausal age. Yeah. Now, what are the risk factors? The risk factors, there are varieties of pathological process which may happen. Atherosclerotic conditions. Then there might be a disrupted valvular endothelial mechanism. Plaque formation may happen. So, in such conditions, if your endothelial linings are disturbed, and when your endothelial linings are disturbed, there is a high chance of developing of plaques. So, when the plaques are formed, your arterial lumen will be compromised. Okay, which may lead, or you can say that when there is a disruption in your endothelial lining, the plaque formation happens. So when a plaque is formed, which will leads to myocardial ischemia. When an ischemia happens, what happens? There will be myocardial infarction or anginal pain will be there. See, you can see how these normal lumens are developing, or how these atherosclerotic conditions are being developing here. See, here you can see the cross section of a normal, the sagittal section of a normal artery, and you can see the cross section of a normal artery. See the lumen is so normal that there is no deposition there. See what happens in this wall. There is a tear in this wall. See, you can see there is a tear in the arterial wall. So when there is a tear in the arterial wall, the WBC will be infiltrated. The glucose will be infiltrated, and it will be deposited there. So once the RBC will go there, and it will try to figure it out. And the other RB, so sorry, WBC, and then the other WBCs is also come, and they'll deposit when there is sugar again. If there is a presence of sugar, the WBC will come there, and it will eat the sugar. So it will eat the sugar in such a way that the WBC will die at that particular place itself. So when the WBCs are deposited at this particular area, again the further again new WBCs are chemotax towards there, and they'll phagocyte the WBCs again. So it will eat the glucose, and it will die from there itself. Thus the plaque increases. Okay. So thus PLAQUE plaque. So thus the plaques will increase in the lumens of the arteries, and it will narrows the circulatory areas, which will block the circulation. Okay. So this is not enough. This is not needed. Now, how will we identify a coronary artery disease? Or see, we can specifically say that coronary artery diseases will be there for a particular longer period of time. When will we identify that the patient is having a coronary artery disease? Only when the patient comes to the hospital with a complaints of what? Chest tightness, a jaw discomfort, and all those things. Mainly the chest pain. So when will the patient develop a chest pain? A patient will only develop a chest pain when the patient identifies that he is having a problem with the coronary artery disease, when the coronary arteries are occluded, and it will seldom gives oxygen to the blood muscles of the heart, right? So that is a particular point when the patient is taken into the hospital. Clear. So the the atheroma or the atherosclerosis will be there for a longer period of time, right? But when will the patient identify that? The patient will only identify that when the circulation is compromised. Clear. So the patient is coming to your hospital. Right. So the patient is coming to your hospital with the complaints of what are the complaints that the patient may have. First thing is that the patient may develop a chest pain, right? So for the chest pain, the patient will be having a chest pain which is starting from the left side of the heart, which can be radiating towards your jaws, towards your shoulders, towards your scapula, and it will descend through your lateral aspect of your hand. Okay, it will radiate through your lateral aspect of your hand. So this is the classical chest pain, and this is a classical chest pain. And let me remind you, all the patients should not have these classical chest pain. Some patient will be having a chest tightness or a chest discomfort, or some patient will complain that they'll be feeling a chest heaviness, like how a 10 kg of weight have been kept on the chest of the patient. So the patient may have feel a chest tightness. In some conditions, the patient will be having dyspnea, shortness of breath will be there. In some condition, if diabetes patient, especially in case of diabetes patient, the patient won't be complaining about pain because the diabetes would have mimicked the pain, but the patient will be sweating. There will be an increased level of sweating for the patient, right? So there might be an epigastric distress. Clear. The patient may say that I am feeling any some sort of abdominal pain. I want to vomit, or the patient may say that I'm feeling nausea. So all these findings are an indication that the patient may have a compromised circulation towards the heart. Right. So when you identify such kind of patient, what is the first remedy? You have done the physical examination and you got that the patient is complaining of these symptoms. So this is the symptom, and you will check the vitals. In some conditions, you can see there is a hypertension, or in some conditions, it will be normal. There won't be any change in the blood pressure also. So soon, when the patient is complaining about any chest discomfort, chest tightness, even if the patient is complaining of epigastric pain also, we will take the ECG for the patient. And you know that what are the findings that we can see in the ECGs depending upon the leads. Like it is V1, V2, it is septal, then anterior, inferior, posterior, lateral. All these walls, how to identify. Now, what is the change in ACs? Acute coronary syndrome. See, there will be P wave, the QRS complex, and there will be an elevation in the T wave. See, usually the T wave should be here, the ST segment should be here, but there is an elevation in the ST segment, which is known as ST segment elevation MI, myocardial infarction. This is the correct finding. So, if the patient is having an ST segment elevation, definitely the patient is on MI. In some condition, see, one thing let me remind you here is that if it is an acute phase, if it is a fresh MI, okay, if it is a fresh MI, you can see in the ST segment elevation. Okay. If it is not a fresh one, which means the see, actually the heart muscles have complaints like ischemia, injury, and necrosis. Okay, there might be an ischemia, there might be an injury, or there might be a necrosis. These are the three conditions which happen to the heart muscles. See, if suppose this is your heart, and your heart is getting, usually the heart is getting a normal blood from your coronary arteries. When there is a sudden occlusion in the coronary arteries, okay, the heart muscles won't receive oxygen, right, the blood. So in that condition, the injury, the ischemia is new to the heart, right? So the heart muscle will be having an ischemic changes. So that ischemia, it is known as a fresh MI. It's a fresh heart attack. So that ischemic changes can be embedded, or it can be seen as an ST segment elevation MI, right? And okay, fine. After the patient is having an injury, after the patient is having an ischemia, the oxygen supplied to this heart muscle, suppose this is a heart muscle, the oxygen supplied to the heart muscle is decreased, right? So at this particular point, there will be ischemia. Then after ischemia, what happens? Continuously the heart is not getting oxygen, right? For example, a patient have developed a chest pain at 12 p.m. Right. So there were not somebody in the room. The patient was left alone for a particular point of time. In some condition, what I have said, in case of diabetes mellitus, the patient may not feel pain also. S- it doesn't indicate that if the patient is not feeling pain, there is no heart attack, right? There will be heart attack, but the patient is not perceiving it. So in such kind of conditions, the ischemia will continue to occur. Okay, the ischemia rises and it leads to injury of these heart muscles. Right. So there will be an injury of the heart muscles. If you are taking an ECG after there is an injury of the heart muscles, it can be seen as P wave. The ST segment will be normal, but you can see an inverted T wave. Okay, there will be an inverted T wave. The inverted T wave indicates there is a necrosis, there is an injury of the heart muscles. Okay, and third one is necrosis. So what happened necrosis? So the injury progresses, and there is a necrosis of this muscle. So when there is a necrosis of the muscle, you can see in the ECG like there will be a deep Q wave. See? there will be a deep Q wave. What is a normal Q wave? It is 1 mm, right? Which we have already explained when we were taking ECGs. So there is a deep Q wave. So these are the three changes which is associated with the coronary artery diseases: ischemia, injury, as well as necrosis. So ischemia can be seen in the ST segment elevation, injury can be seen in the T wave inversion, and necrosis can be seen in what? Q wave elongation. Clear? Any doubt in this portion? Do I have to explain it again? Guys, do I have to explain it again?
No, sir.
So that's about the ECG changes in the ST segments. See, likewise, if there is an ST segment elevation, there is an ST segment depression also. Okay, this ST segment depression also indicates there is a heart issues. So anyhow, ST segment elevation is very predominant, but ST segment depression, in case of ST segment depression also, it may indicate a coronary artery syndrome. So when you got these ECGs, see, if you are seeing this STEMI, the ST segment elimination, nothing have to be done. It is simple, as simple as it is myocardial infarction itself. So we have to take the patient to coronary angioplasty. So what will we do? We'll just identify which blood vessel is affected. So we can identify the which blood vessel is affected by looking into the ECG itself. But we want to know how much these blood vessels are involved, whether it is 60%, 70% occlusion is there, 80% occlusion, 90% occlusion. We have to identify what is the amount of what is the amount of occlusion that have affected to the coronary arteries, right? So to identify the coronary artery, how much occlusion, suppose this is a coronary artery, this much is the occlusion. So we'll go with the coronary artery angioplasty. So how we'll do a coronary angioplasty? See, uh, yeah, coming to this patient, this area. Suppose what we are doing is a coronary angioplasty. So suppose this is a blood vessel, say blood vessel, and here you are having an occlusion. So what will you do is that first one, so see, we'll go with angiogram. So what is an angiogram? We will insert a catheter through the femoral artery to the radial artery, so, or any other applicable arteries. Then it is a branch of the corona. It is a branch of the aorta, right? So we have to reach aorta. How will we reach aorta? We can't go through the pulmonary veins. There is no access through the pulmonary veins. Only access uh, is by your superior vena cava or inferior vena cava. So this is the area which usually they'll introduce a catheter. So through the superior vena cava, the jugular art, the jugular arteries. Okay, sorry, the jugular veins. Through the jugular veins or your femoral veins, a catheter will be passed to here. Okay, and here we have a normal. Here we are having a normal opening, right? So we'll pass the catheter through this area, then through here, and it is again entered into the coronary arteries, right? So this is one method. So once we have an access to the aorta, we'll move the catheter to the coronary arteries. Right. So when we'll move to the coronary arteries, a dye will be injected. So a dye will be injected and we'll identify and we'll take multiple X-rays. Okay. We'll take multiple X-rays and we'll identify what is the status of the clot. So once we identify, okay, the clot is around 60 to 70%, we'll go for the angioplasty. Clear. And if the clot is more than 80 to 90 percentage, okay, we'll go for CABG. Fine. So it depends upon the clot. Usually, if the clot is around 60 or 70 or more, then only you will be having heart attack. Otherwise, the circulation, this 50 percentage of blood is enough to supply oxygen to the muscles. Okay, if it is more than that, we'll go for these angioplasties. Okay. In only that condition, the patient will be drawn into your hospital. Otherwise, the patient won't come because there is no clinical findings for that patient. if you do an angiogram for me, for you also, there might be some sort of clot will be there. So it might be a 10% clot, there might be a 20% clot. So we are not aware of that because the heart muscles are getting enough oxygen. Okay. Once the heart muscles are not getting enough oxygen for their requirement, then only we'll be having a heart attack, or the heart will be producing such kind of symptoms. Right. So coming back to the coronary angioplasty. So we have done an angiogram, we have identified there is a block, then we'll go for angioplasty. Okay. It is known as percutaneous coronary angioplasty. So the percutaneous coronary angioplasty, we have lot of methods for that. First one is a balloon angioplasty. So what we'll do in a balloon angioplasty is that we'll introduce this catheter, which is a balloon tipped catheter. Okay, we'll introduce this balloon tipped catheter to this area and we'll inflate the balloon. Okay, we'll inflate the balloon with an air. We'll inflate this balloon with air. So what happens when this balloon is inflated? When the balloon is inflated, this atheroma will be pushed towards the walls of the arteries so that it may have an adequate supply of the oxygen. Okay, this is balloon angioplasty. The main risk is that, see, since there is a leftover atheroma here, there is again chance for developing increasing in the size of this atheroma. Fine. So that is the problem with the balloon angioplasty. So in order to come out of this condition, we have introduced stent angioplasty. So what we'll do in the stent angioplasty is that we'll be having a catheter with a balloon tip. In the balloon, we'll keep a stent, right? And we'll keep put this area and we'll inflate the balloon. When the balloon is inflated, the stent will be in that portion. Okay, so here you can see a stent. This stent will prevent the further development of the clot and it will enhance the circulation of the blood oxygen to the heart. Okay, this is the stent angioplasty, and we have medicated stent angioplasty also. So in this stent, we'll be having medicines. The medicines will be the medicines will be giving the stent will be giving medicines to these blood vessels for 5 years, 10 years, or 15 years, depending upon the making of the stent. So which is known as a medicated stent angioplasty. Now we have another method which is known as a laser atherectomy. So what we'll do in a laser atherectomy is that this catheter tip will be having a laser, and by applying the lasers, we'll cut the atheromas and we'll suck it up. That is a laser atherectomy. Okay, so those were percutaneous coronary interventions or percutaneous coronary angioplasties. Stent stent placement, medicated stent placement, balloon angioplasty, as well as laser angioplasty. Clear. And next condition, if it is a 80 to 90 percentage, what will we do? We have to go for CABG, right? Now what is CABG? Suppose this is your artery, this is your main coronary artery having an occlusion of more than 90 percentage. Okay, so what will we do? There is no point in doing the coronary angioplasty. Only option is to do the CABG, right? So what will you do to have a CABG? So we'll take the vein from the femoral vein or your saphenous vein. So any vein will be taken from your leg. Then we'll bypass this area. Okay, we'll bypass this area like this. See, we'll bypass the area like this. So what happens? A blood which should be gone to this area will be redirected to these corona through these bypassing area. Okay, so usually the blood will go like this. Okay, we'll bypass this block. See, if a road is having a block, huge congestion, the people will take a bypass road, right? Likewise, it is a how it is done in the coronary artery bypass grafting. If there is a block in the main artery, we'll do a bypass grafting. Okay, so in two arteries, three arteries, these bypass grafting can be done. Okay, so that's about the CABG. Clear? Any doubt?
Yes.
I hope you are understanding this, right? And coming back to this, so this was about STEMI. Okay, this was about STEMI. Now, the patient is complaining about chest pain, but the patient is complaining about chest pain, but your ECG is normal. You are having a normal ECG. What will you do? See, in such condition, if a patient is complaining about severe epigastric pain, okay, and when you take the ECG, you can find that the ECG is normal one. So what will you do? You will just give injection pan-dope and we'll keep the patient to settle. Okay. After giving pantoprazole also, you have given the gelusil also to the patient, the antacids also to the patient. You can't find a relief for this epigastric pain. The patient is still complaining about epigastric pain or epigastric distress without a decrease in the pain. So in that condition, you have to access for NSTEMI. What is NSTEMI? It is non-ST elevation MI. Okay, the patient is complaining about anginal pain. The patient is complaining about epigastric pain, but your ECGs are normal. So such conditions are known as STEMI, NSTEMI, non-ST segment elevation MI. So if the patient is having NSTEMI, or if the patient is having T inversions. So in such condition, the confirmatory diagnosis is your troponin I. So you will go with this or trop T. There are two things, troponin I or as well as troponin T. Okay. So what is the main difference between trop I as well as trop T is that if a patient is having CKD, okay, if a patient is having CKD, trop I is more reliable. Okay, that's why it's better to go with tropi. Okay, so the tropi values you can see the normally the tropi value is 0.004 nanogram per deciliter. It should be less than this 0.004. It should be less than that. That is a normal tropi value. So there are two types of tropis. One is a card test, and second one is a qualitative test, which we'll get as a lab value. Okay, card test is not such kind of relevant as well as significant. In some conditions, if the value is so high, then the tropi card will be positive. Otherwise, it's always set to check the lab values of the tropi. Okay, so if the value is 0.08, we can say it is positive tropi, right? But if it is 0.08, it won't be reading in the card. So there is a difference in that. So that's about the ECG, right? So if there is no change in the ECG, we have to go for the tropi. If the tropi is positive, okay, if it is more than 0.05, we'll take this patient, NSTEMI patient, for the coronary angioplasty or coronary angiogram. If your tropi is a negative, okay, if your tropi is a negative and your patient is still having ECG, if your patient's tropi is negative and there is no changes in the ECG, but the patient is having pain, then we'll just observe the patient, okay, and we'll take hourly serial ECG. Okay, so again, if the patient is having epigastric pain, there is no serial. We have taken 4 or 5 ECGs, and there is no change in the ECG. Tropies are still negative. So we can diagnose the patient. Either the patient will be a psychiatric condition, okay, because since we have given everything, the patient is not settling. Patient is still complaining about chest pain. Okay, so might be the patient psychiatric. Other conditions might be which is very clearly with the abdominal areas. So severe gastric ulcer might be a culprit, or in that condition you can give injection pantoprazole 80 mg as an infusion. Okay, and we can go with the smooth muscle relaxants like buscopan, hyoscine butyl bromide can be given, or an injection cyclopan, dicyclomine sodium, an injection cyclopam can be given. So in such conditions, when the smooth muscles are targeted, it may decrease the pain. And if it is associated with your skeletal muscles, you can go for the diclofenac sodium injection or an injection paracetamol 1 gram IV will do. So if the patient is not settling in such kind of condition, the thing is we can go for an emergency USG. Okay, so in such if we are treating the patient like this, any sort of complaints can be rectified, and we'll be able to find that. In the meanwhile, also you have to monitor the heart values like the ECG also. See, if there is no indication in the ECG and if there is no indication in the tropi, we won't take the patient to the coronary percutaneous interventions. Okay, we won't take the patient for this. condition, because the when we are doing such kind of things, it itself may cause some sort of complications. The dye may cause complication. See, the kidneys may be having a problem with the dyes. Okay, so we won't take such kind of risk. And if you are having if these things are done, if your ECGs are finding problems, we'll also do an echo to understand what is the functioning of the heart, what is the ejection factor of the heart. Usually the echo is done to identify the anatomical structure of the heart, right? The cardiac output, the valves, whether what's the status of the valves, and so on. Okay, then no, coming back to the STEMI. So we, in your hospital, in you're working in a casualty, you have identified a patient with STEMI, right? So you have identified a patient with STEMI, then we'll give a loading dose to the patient. Okay, it is ecospirin 300 mg, ecospirin 300 mg, clopidogrel again 300 mg, then etorvas 80 mg. So this is the loading dose which will be given to the giving for the patient. No, again, if the patient, if in some conditions the patient will be a normally known case of CAD and the patient will be on ecospirin as well as clopidogrel. So if the patient have taken the ecospirin as well as clopidogrel in that particular day itself, then we'll get a booster dose. Or like this, ecospirin will be given 150, clopidogrel will be given 150, and the atorva will be given 40. Okay, so this is the dose when we'll give the patient if the patient have taken the ecospirin and clopidogrel at the same day. Otherwise, this is the drug of choice. Okay, so we'll just do the initial loading dose. We'll just give the initial loading dose. Previously, what I have said, we were giving thrombolytic agents. Okay, streptokinase as well as urokinase were given in such kind of condition. But in usually nowadays we are having this monitoring areas, so we'll just go with the monitoring substances. Okay, next is we'll go with the medicines like aspirin, ecospirin. That is ecospirin, right? And if there is a BP problems, okay, we'll go with the beta blockers, AC inhibitors, and such kind of conditions. It depends upon the condition of the patients of the patient. If there is BP and so on, then channel blockers. It depends upon. So we'll go for the nitrates. What's the function of the nitrate? It is the coronary vasodilators. So this nitrates are given sublingually, and you have to strictly monitor the blood pressure of the patient. Okay, so that's the management. These are the surgical management. We have explained it. Bypass grafting. We have explained it. Okay. Now then, second, which is associated, second condition which is associated with the coronary artery diseases are the angina pectoris. Okay. So what is an angina pectoris? Angina pectoris is nothing but your severe chest pain. Right. So you know the angina pectoris. It starts from your chest. It may radiate to your jaws, to your shoulders, to your back, to your left hand. Okay. So that's the angina pectoris condition. Next, the condition is a myocardial infarction. Same. It is same as your coronary artery diseases. For the exam point of view, we have covered the entire coronary artery disease, right? So you know these things. See, the things which I am skipping is not for your exam. Okay, that's why I'm just skipping all these things. We don't want such kind of things. So we have completed the coronary artery disease. I have explained the MI in the coronary artery disease itself. Next is the rheumatic fever. What is a rheumatic fever? It's an inflammation due to the streptococcal infection. It's a group A streptococcal infection. Kindly note that if the rheumatic fever is due to a group A streptococcal infection. Okay. So in case of rheumatic fever, kindly note, kindly understand this. There might be subcutaneous nodules. Okay. There might be edema. What is the reason? Heart failure is the reason. Okay. Erythema will be happen. Erythema will be happen. See, such kind of things are known as erythema. There will be a fluctuating fever. Okay. Then the main clinical feature of rheumatic fever is sore throat. Okay, there will be sore throat. Then polyarthritis. What is polyarthritis? You'll be having pain in multiple joints. Okay. So if heart is involved, you will be having carditis, infection to the heart muscles. Dyspnea. Why? Because of congestive heart failure. Okay. Syncope. BP fall will be there. Pericarditis. So any infections which affects the heart will leads to pericarditis, infective pericarditis or infective endocarditis. Okay. These things are less common. No need to study that. Okay, so in case of rheumatic fever, we were talking about the rheumatic fever. It is caused by group A streptococcal infections. What are the symptoms that you have to check? There will be erythema, will be the edema will be there because of congestive heart failure, and dyspnea again with the congestive heart failure. Pericarditis or endocarditis will be the polyarthritis, sore throat, as well as fluctuating fevers will be there. And also you can see nodules, subcutaneous nodules will be present. Clear? So that's the only thing which you need to understand for your exam. Clear. So we have explained all the clinical features. That's enough. It's enough. So how will you do? See, while taking the ECGs also we can see whether there is a pericardial changes or there is an electrical conductivity problems or not. Usually echo is the first choice. Then we'll check for the blood levels of anti-streptolysin O titers, which is to identify the group A streptococcal infections. Okay, let's leave it. Leave it. Leave it. Next one. This is important again. Next is rheumatic heart disease. This is important in your coronary artery disease. The rheumatic heart diseases. See, rheumatic, the most common thing is that there will be murmurs. So, why a murmur happened in case of rheumatic heart diseases? Because it will be affecting your valves of the heart. Okay, that is rheumatic heart diseases. Kindly note in case of rheumatic heart diseases, there will be problem with your heart murmurs. So the murmur mean it is associated with your valves of the heart. Right. Now, what are the etiological factors? What are the causes of these rheumatic heart disease? Again, rheumatic fever is the primary cause of rheumatic heart disease. Okay, rheumatic fever is the cause of primary rheumatic heart disease, and it is caused by group A streptococci. Okay, so streptococcal sore throat, streptococcal pharyngitis, all these things can be seen in rheumatic heart diseases. And we have said that the rheumatic fever will affect the heart muscles. Since it is an infection, it affects your heart muscles, right? So the rheumatic heart disease will affect the valves and or the muscles of the heart, which leads to valvulitis as well as myocarditis. Okay, see, we have said pericarditis, which is affecting the pericardium. If it is affecting your endocardium, it is called as endocarditis. If it is affecting your muscles, it is called as myocarditis. And again, the main problem with the streptococcal infections is that it will affect the valves of the heart. So when the valves of the heart will be affected, it may leads to insufficiency of the valves, like it may leads to stenosis of the valve. Okay, the proper functions of the valves will be impaired. That's why you can see you can hear murmurs in the heart. Okay. Kindly note in case of rheumatic heart disease, streptococcal infection is the main cause. It will affect the heart. That's why it is known as rheumatic heart disease. It will affect the valves. It will cause the stenosis of the valve. Okay. It will cause infection to the layers of the heart. Pericarditis, myocarditis, and endocarditis. Okay. In mouth, you can see pharyngitis, and there will be distant neck vein will be distended. See, jugular vein extension can be seen. Bluish color, bluish discoloration of the skins can be seen. See, you can see the discolorations. Okay, that's enough, my dears. The point what I am saying is more than enough. Okay, don't go further. Your exam won't ask such kind of questions. Only the points which we'll be dealing will only be asked for your question, for your prometric examination, and your the management of the rheumatic heart disease. See, first one is symptomatic management. We'll give the corticosteroids, hydrocortisone, such kind of things to decrease the immune response of the body. Second thing is we know that it is a streptococcal infection, so we'll treat with the antibiotics. Okay, So second one is heart failure, or you can call it as a congestive heart failure. Okay, so let me kindly write it down. Kindly write these things down. We have left-sided heart failure as well as right-sided heart failure. Okay, we have left-sided heart failure as well as right-sided heart failure. The left-sided heart failure is more common when compared to right-sided heart failure. So what do you mean by a heart failure? The heart failure means the heart is not able to pump the actual amount of blood which is required for your body. Okay, the heart will not be able to pump the blood which is sufficient for the body's needs. That is heart failure. Okay, so kindly write the lecture notes. Kindly write the notes down. What are the main signs and symptoms of left ventricular heart failure as well as right ventricular heart failure? Just mark it as like signs and symptoms like this. Left ventricular failure and as well as right ventricular failure. Okay, first symptom in the left ventricular failure, there will be dyspnea. Okay, there will be dyspnea. Kindly write it like this. There will be dyspnea. And what is the characteristic of the dyspnea? It will be paroxysmal nocturnal dyspnea. The patient may have a paroxysmal nocturnal dyspnea. Kindly write it. In left ventricular failure, the patient will be having dyspnea, which is paroxysmal nocturnal. There will be a paroxysmal nocturnal dyspnea. And next, the patient will be having fatigue. The patient will be having fatigue. The patient will be having restlessness. The patient will be having restlessness. Then there will be cyanosis, the peripheral cyanosis. There will be peripheral cyanosis. What about the urine? There will be decreased urine output. There will be decreased urine output. Blood tinged sputum. Blood tinged sputum. So in case of left ventricular failure, there will be blood tinged sputum. See, I want to add one exam point here. One is blood tinged sputum. Blood tinged sputum as well as pink frothy sputum. Pink frothy sputum. These are the two conditions. Okay. Blood tinged sputum. So this can be seen in left ventricular failure, and pink frothy sputum can be seen in pulmonary edema. Okay. Kindly write it down. Pink frothy sputum. It can be seen in pulmonary edema, and blood tinged sputum can be seen in left ventricular failure. So that's about the signs and symptoms of your left ventricular failure. Second one is your right ventricular failure. In right ventricular failure, you can have abdominal pain. There will be abdominal pain. Then bloating will be there. See, the main thing, even though you don't have to study these things, only identify like this. See, suppose this is your heart. If your left ventricles have failed, this area is failed. What happens? If this area is failed, okay, left failure. If there is a left failure, what happens? The cardiac output will be decreased, right? So when the carbon cardiac output is decreased, what happened? The aortal blood also will be decreased, right? So when the aortal blood will be decreased, what happens? See, the main vital organs. One is your brain. Okay, one is your brain. Second one is your kidney. Okay, so the supply to the brain as well as the kidney will be decreased. Once the circulation to the kidney will be decreased. See, when you pump the blood, 1/4 of the blood goes to your brain. The other portion, the other 3/4 will only be circulated to your entire body. Right. When the circulation to the kidneys are damaged, what happens? There will be decrease in the urine output. Right. So this is how we can identify. And again, if the circulation, if the cardiac output is decreased and there is no supply to your extra circulation. See, the point is, when you're having a 1 liter of blood to be pumped, suppose, kindly understand like this: if 1 liter of the blood should be pumped to your body, that is a normal amount of blood which have to be pumped to the body, right? So when this 1 liter of blood is supplied to the heart, supplied by the heart to the entire portion of the body, it will give 250 ml to the brain, 250, 200 ml to the kidneys, 150 to your what your liver, 150 to your stomach, the other portion to your skin, to your glands. It will divide, it will distribute evenly to the entire bodies. Okay, so if it is getting its proper 1 liter of blood, what happens if the heart is not able to pump the 1 liter of blood? It is only pumping 500 ml. What happens? The body will understand that the heart is pumping only decreased amount of blood, so that I have to use it wisely. See, it is like how you are using the water. See, in normal winters, you are getting adequate water. In summers, in some areas, you are not getting water. See, you have to give price for the water which comes to your home, right? If it is getting in your tanks, the persons from Tamil Nadu, especially in Chennai, will understand the scarcity of the water, right? So, what happens in such conditions? You take bath each and every day if you are not getting water? No, the people in the class will not brush if they are not getting water, right? So it depends upon how we have to organize the how you have to organize and how you have to utilize the water which is getting in a scarcity level. Likewise, just a minute, somebody is want to join the class. Likewise, yeah, kindly switch off your mic. Kindly switch off your mic. Likewise, likewise, the heart will the body will understand, okay, I am getting a decreased amount of blood to the body parts. So what happens? It will redistribute this 500 ml of blood to the vital organs, to the brain, to the kidneys, to the liver, and it will decrease the supply of oxygen to your skin, because skin is not mandatory for this patient, right? So the functioning of the vital organs are important, so it will decrease the circulation to your skin. That's why this patient is having, the left ventricular patient is having what? Peripheral cyanosis, right? So that is the reason the patient is having a peripheral cyanosis. Clear with that? In same condition, if there is a right ventricular failure, okay, we have said that there is, in right ventricular failure, we have said that the patient will be having abdominal pain. Okay, then bloating will be the bloating, jugular venous distension. Mainly, there will be jugular venous distension. Okay, ascites will be the ascites, and increased central venous pressure. Why central venous pressure? Because the inferior vena cava as well as the superior vena cava is affecting your right atrium. Okay, this is the central venous pressure. Okay, right atrial pressure will be increased. Why? Because this right ventricle is not pumping blood to the heart, to the pulmonary arteries. So when this right ventricle is not supplying adequate pulmonary circulation, what happens? The blood inside this area, these chambers will increase. Okay, the amount of blood, the pressure of the blood will be increased in these chambers, which will eventually cause an increase in the pressure in these superior vena cava, thus by increasing jugular venous pressure. Okay, when there is a jugular venous rise in the jugular venous pressure, we can say that there is a problem with the right atrium as well as your right ventricles. Usually, the right ventricles are the culprit. Okay, then there will be a respiratory distress. Why respiratory distress? Because the lungs are not receiving adequate supply of oxygen. Okay, then hepatomegaly will also be there in case of right ventricular failure. Okay, what is anasarca? What is anasarca? It is complete body. The body, entire body will be having uh, edema. That is anasarca. Clear. So clinical features, again coming to the heart failure, we'll be having the clinical features like pedal edema, dyspnea, congestion of neck vein, that is JVP, jugular venous pressure, cyanosis, fatigue, and other complications, signs and symptoms which we have said here. Okay, all these signs and symptoms will be see swelling of the abdomen. Okay, pleural effusion will be there. Excessive fluid will be around your lungs. This pleural effusion is mainly seen in right ventricular failure. Okay, pleural effusion. Okay, now how will you diagnose it? Right ventricular failure as well as left ventricular failure. If V1 it is RS greater than 5 mm, we'll say that right ventricular failure. V6, if the R wave is more than 25 mm, it is left ventricular failure. See, from the ECG, you can identify whether it is a right ventricular failure or a left ventricular failure. And if you're identifying this one, echo is the choice, and we'll correctly identify the measurements of the heart. What is the treatment? See, if it is failed, there is no actual treatment for this. We can't revert it. Okay, we can revert the condition. The thing is, we can decrease the oxygen consumption. So how we have to do the decrease oxygen consumption? See, if your body is a huge one, the oxygen have to be supplied to the entire body, right? When if your heart when the body is the lean one, okay, there is no point in that you have to supply to your heart. There is no point in that the heart have to supply the entire huge body. So weight reduction is the main thing, and monitor weight. Why monitor weight? Edema is the problem. Okay, we have to monitor the edema. See, usually if there is edema, the patient will be gaining weight by 1 kg, 2 kg in a day itself. It might be it not be because of the food which the patient intakes, but it is because of the fluid which the patient is intaking. The patient might be drinking water. Okay, so the you have to monitor the weight of the patient in order to check the edema. Sodium restrictions. See, the sodium will exacerbate the heart failure. So you have to restrict the sodium. Fluid restriction should be there. Why? Because or what are the fluid the patient will be taking? It won't be wasted towards the urine. There will be decreased urine output. So the IO chart, simply the IO chart, intake output chart. If the patient is taking 3000 ml of fluid, there should be minimum of 2700 or 2800 output should be there. Other 200 to 300 ml will be lost by sweating or through your respiration. Okay, so what happens in case of edema is that if you are taking 3000 ml, there will be only output of 1000 or 1500 ml. Rest 1500 will be accumulated in the body itself. So where the body will be accumulating this fluid, it will be as an edema. Okay, so around the lungs, if the fluid is around the lung, we'll call it as pleural effusion. Okay, if it is in your ankles, in your leg, call it as angle edema. If it is around your abdomen, we'll call it as ascites. Right. So, or it can be in your cerebrum, in your brain, which causes a cerebral edema. Okay, cerebral edema can be happen. Then all over your body, which we call it as anasarca. So such kind of edema can be happens. That's why we have to restrict the fluid which is taken for the patient with congestive heart failures. Right. Then stress reduction. Stop smoking. If the patient is again smoking, you have to stop the smoking. There is no point in treating the patient if the patient is again smoking. Yes, any doubts? Guys, any doubt?
No, sir.
Okay. Then pharmacological management to understand the circulation. There is edema, you have to go for diuretics. So loop diuretics is the first drug of choice. Then this one for BP management. Okay, for the BP management, all these things are for the BP management. Digoxin, cardiac glycosid. So We have studied the digoxin. It will increase the force of contraction. Okay, it will increase the force of contraction. When the force of contraction is increased, the cardiac output will be increased. So digoxin is a drug of choice for heart failure. Next is cardiac arrhythmias. Okay, so what do you mean by an arrhythmia? Abnormal rhythm in the heart. We have two types: atrial arrhythmia as well as ventricular arrhythmias. Okay, atria can be arrhythmic as well as ventricle can be arrhythmic. We know the drugs. Okay, you have identified all the drugs of the arrhythmias. So I won't go into the management portion. You know what is tachycardia is? More than 100. What is brady? 60. You know heart block, right? First degree heart block, second degree heart block, Mobitz 1, Mobitz 2, and third degree heart block. You all know these things. Okay. See, we have, you know what is atrial fibrillation is, right? So the fibrillating P wave followed by a QRS, fibrillating P wave followed by a QRS. And it's atrial. See, and you can see the RR interval. Here the RR interval is normal. But what happens here? The RR, see, you can see the RR difference between the RR interval. It is not normal. Okay, it is an arrhythmia. See, atrial arrhythmia as well as ventricular arrhythmia. Kindly take the screenshot. These are the treatment which we are giving. Okay, for the atrial arrhythmias as well as ventricular arrhythmias. You know the drugs, we have explained these drugs: class 1, class 2, class 3, class 4, and drugs. So in which arrhythmia we'll give which drug? Okay, in atrial arrhythmia we'll go with the digoxin, propranolol, quinidine, anticoagulants such as warfarin or comodine. The ventricular arrhythmia we'll go with procainamide, phenytoin as well as propranolol. See, physical manner. See, antiarrhythmic drugs. Then electricity, electric cauterization. No questions will be coming from these things. Okay, they'll only focus on the antiarrhythmic drugs. I'm just skipping these things because it is not needed for you. Okay, the pregnancy is also congenital heart diseases. This congenital heart diseases will be dealt in the pediatrics. Okay, there is much more to explain the in the. So that's about the basics of the cardiac diseases. So we have complete the cardiac diseases, and we have yet another some diseases remaining, like this varicose vein, peripheral diseases, Raynaud's diseases, aneurysm, shocks, and some among those are remaining. So we'll discuss those in the next class. Okay.